three reasons for it. First of all, because it has been imported from communities where the urban-rural divide is minimal, such as UK, Canada, New Zealand, Finland, Norway, and many more. While this is clearly not the case for Indonesia, as it is a big country, literally, with rural and remote communities that are heterogeneous with great diversity in terms of social, political, ideological, economic, and special contexts. And different types of rural and remote communities may have distinct socio-economic characteristics as well as health needs. And second, because it is based on, I think it is based on a rigid urban-rural binary model that target disparity rather than accommodating the diversity of rural communities. And the reason for me saying this is because it assimilates rural and remote communities into a single undifferentiated aggregate and then compare it with urban communities. And this is unfortunate as Indonesia has a diverse spatial context ranging from major cities, regional areas, remote areas to very remote areas such as island in the Far East areas. And in the Indonesian context, the term rural might be closely linked to regional areas, but it doesn't adequately represent remote and very remote areas.
And just, can I interrupt you here? Sorry, but can we just finish a introductory round and then can we continue with this? Yeah.
Okay then. Well, yeah, that's for me. Thank you.
No, and warm welcome to you. Yeah. Dr. Asita.
Thank you very much, and I'm really glad to be in the forum. I'm a rural doctor in Sri Lanka, and I graduated from University of Colombo, Faculty of Medicine in 2005. I have about 20 years experience, more than experience on rural health and public health, as well as mental health. And my interests are to seek more regarding rural health and also to help people in these remote areas. And I'm really 250 kilometers away from capital Colombo. So I'm really glad to be with you, and my perspectives on public health I will share with you. Thank you very much.
Warm welcome to you. Who would like to go next?
Hello?
Yeah, yes, Asma. Go ahead.
Hello, good afternoon. It's me, Asma Munir. I am by profession, I am a clinical psychologist. I have done masters in psychology, followed by diploma in advanced diploma in clinical psychology. And after that, I did my master program in public health from KIT, Royal Tropical Institute from Netherlands, and I'm still in Netherlands. Back in Pakistan, I worked as a clinical psychologist in public and social sector almost for 6 years, and I worked for 1 year in our for 2 years in our rural area as a clinical psychologist. So today I am here to learn more about the problems. That is it similar in all the in our countries, or is it different? So that's why I'm here, and I love to hear from you people. Thank you.
Welcome. Warm welcome to you. Kin, would you like to give an intro?
Yeah. Good morning, good afternoon, and good evening, everybody. My name is Kin, and I'm from Myanmar. I'm a medical doctor by training and just finished a master in international health degree in the Royal Tropical Institute recently. Recently, together with the Angie, Sneha, and then prior to that, I've been working in the public health field for almost 10 years, working in the various international health, international and local health non-profit organization to serve the to serve the population in the your area, and also like to provide the technical assistance to their Ministry of Health for the maternal child healthcare project, immunization projects, and also malaria and TB control activities. And also I have some experience in the health emergency situation, and also health program development and health research activities with some UN organizations. Today I'm one of the panel, and I'm very happy to be part of this panel. And thank you, Sneha, for inviting me to share my knowledge and insight and experience. Thank you.
Welcome to you, Kin. Dr. Ganesh.
Hi.
Oh, sorry, Dr. Chani, please go ahead.
Yeah. Hi, myself Dr. Chandni. I'm from India. Good morning, good afternoon, and good noon, and good evening to all. So basically, by profession, I am a dentist. I did my graduation in dental surgery, and then I pursued my master's in public health. And currently, I'm working in a WHO project which is based on aging and the problems of the geriatric population. So it is a kind of wave 2 of the project, and we are looking for the problems of the geriatric. So we work both for the urban and the rural area. Thank you for inviting for this brainstorming session. Thank you so much.
Warm welcome to you.
Thank you.
Mr. Nachiket, would you like to introduce yourself?
Sure. Thank you, Sneha. Hi all. Good evening. My name is Nachiket Kudi, and I come from India. I have a bachelor's training in health informatics, followed by post-graduation training in public health with concentration in epidemiology. I come from both a research and a practice background. I specialize in evidence synthesis, mixed methods research, and my practice has been around working for mobilizing medical oxygen in the state of Karnataka in the remote parts. So yeah, we have some bit of experience in tribal health and rural health as well. Thank you. Looking forward to engage with all of you. Thank you.
Warm welcome to you. Dr. Ashlesha, can you go next?
Hello all. Good morning and good afternoon, good evening. First of all, thank you so much, Sneha, that you invited me to be a part of such a vibrant panel, and really looking forward to this. I am Dr. Ashlesha Taude. I'm Major Dr. Ashlesha Taude. I'm from India, and I have served in the armed forces for a while at the borders, and as a doctor from armed forces, I have seen the rural and remotest of the villages from really close. Presently, I am rural health training in charge and assistant professor in one of the medical colleges in Mumbai, India, and we look after some of the tribal villages in Western Ghats of India. There are certain tribal pockets to which we cater, and we not just look at the health aspect of it, but also an overall development, and that is how actually rural proofing interested me a lot, and I'm looking forward to real good insights from such a diverse panel, and let's just go ahead. Thank you.
Warm welcome to you, ma'am. Dr. Satabdi, can you go next?
Good morning, good afternoon, and good evening to everybody. I'm very much grateful to Dr. Sneha so that she has arranged such a wonderful platform for us. I'm Dr. Shatabdi Mitra. I am currently working as assistant professor in Campus Medical College and Hospital in Kolkata, West Bengal. I have rural experiences for a few years back, that is in some rural and very underprivileged areas of West Bengal, where we have worked with household food insecurity. And currently I am also working for the immunization services and in the rural areas as well as among the backward people living in the urban areas. I have some working experiences among the tribal population also. We have worked, and I, with my team, have worked for the different national health programs, like as for the tuberculosis, leprosy, like this. I am very much hopeful to have experience and learning by sharing here. Thank you.
A warm welcome to you. Dr. Ganesh.
Yeah, hi, hello everyone. I'm Dr. Ganesh Nair. I have been working earlier before my MD. I have been working in a clinical setup, like in a hospital, for almost 3 years. After that, after completing my MD, of course, during MD, I have had enough of rural exposure. After my MD, I have worked with World Health Organization, WHO, as a surveillance medical officer. So I was posted in the state Uttar Pradesh in India. So I have been looking after 4 districts in that state. So I have had the opportunity to work as a surveillance medical officer along with the government authorities and also with the local population quite closely. Not just the highest of the government authorities, even the baseline workers, I mean, the grassroots workers like the Ashas and Anganwadis that we have in India. Currently I have returned to my hometown in Mumbai, and I am on the verge of setting up my own clinic. And I'll be, of course, along while working in my clinic, I'll also be setting up some project which would be associated with rural health in some way or the other. So that's on the way. I mean, I'm still maybe a month or 1.5 months still into it. So that's it for my side as of now.
A warm welcome to you, sir. Can we have all the research team to introduce themselves? Professor Ian Cooper and Takani.
Good afternoon, everyone, and it's a pleasure to be with you. I'm Ian Cooper. I'm the director of the Kwanda Center for Rural Health at Stellenbosch University in Cape Town, South Africa, and a member of the executive of the Wonka Working Party and Rural Practice, and one of the co-leads of this research project, which led to these regional rural cafe discussions. And I'm really looking forward to this discussion. It's a great turnout today. Thank you.
Warm welcome to you, sir. Takani.
Hi everyone, I am Divuo Takarani. I'm from Stellenbosch University, Ukwanda Center for Rural Health. I work hand in hand with Prof. Ian Cooper on this project as the assistant, and I'm looking forward to hearing all your ideas and perspectives.
Glad to have you on board. Anybody else who would like to introduce themselves?
Hello everyone, my name is Innocentia Lidera. I'm also at Stellenbosch University in South Africa. I work with Prof. Ian and Ndiwo. Thank you.
Welcome.
Hello, this is Govind from Sri Lanka. I'm a family physician and visiting lecturer in the family physician department, as also the council member in the World Wonka Rural Practice. So I'm board man to the rural cafe. Anyway, I will observe from that. Thank you.
Warm welcome to you. So I think we'll begin with our panel discussion for today. So my first question to this esteemed panelists, what exactly do you understand by rural proofing or rural impact assessment? And what is the role you think you play? And why do you think it's important? Feel free to address it in parts or just start the discussion. The floor is all yours. And since we have people from all over, I think we'll have a diverse discussion over this.
Shall I go ahead?
Start from Sri Lanka.
Sure.
Okay. Let Sri Lanka begin.
Okay.
Thank you, Ganesh. Sri Lanka from 1978, of course, we have very similar concept to rural proofing, because we have a very good established public health infrastructure in Sri Lanka. But you may have heard right now we are on the verge of a very bad economic crisis. Forget about that. But we have very good indices, health indices, like very similar to developed countries. So from 1978 through this public health infrastructure, we have gained that achievement. To speak more about rural health in Sri Lanka, we have divisional hospitals and rural hospitals and primary care medical units, and in the apex base hospitals and tertiary level hospitals. So all over the Sri Lanka, we have a very good network of health infrastructure, and more on that, as a government policy, our health is free to all. So now the World Health Organization is telling us about health to all, the universal health coverage, 100% to everyone. So we have established that, and we are really proud to tell all of you that rural health in Sri Lanka is a great national achievement. From time to time, from World Bank as well as from WHO, we get funding to increase rural infrastructure more and let the people enjoy more free health. And the education also is free to all in Sri Lanka. So through education and free health, we like to, or we expect to achieve more towards general public. Let others share their knowledge.
That was a very interesting perspective. Thank you. Dr. Ganesh, you were starting off.
Yeah. Yes. So the first two questions you have asked, that is, what do you understand by rural proofing or rural impact assessment? So as per my understanding is rural proofing is basically, it's kind of a commitment by the government to review and examine the various public policies that it applies to ensure that the rural areas are not disadvantaged, right, in any way. Because many times whenever the public policies are applied in the government, most of the times, a lot of times, the urban areas invariably get the advantage of those policies more easily as compared to rural areas. So it's the job of the government to review and examine whether all the public policies which are applied, whether the rural areas are getting the advantage of it at the best level possible. So it applies not only to healthcare, but it applies to any public policy that we usually see. So the various rural issues that we see normally is like poverty, illiteracy, unemployment, lower living standards, lack of facilities, and also lack of healthcare services, even crime and social evils, all these kind of problems which usually plague a rural area. The various public policies have to address all of these issues so that the overall development of the rural area is possible. One of them is healthcare. Actually, one aspect of the various policies of healthcare. So the way Dr. Asita just said, that they have right from community to district level, they have various hospitals. All the Indians here, they all know that we have setups right from primary healthcare at the rural levels, at the village levels, to community health centers, to district hospitals. So we have an elaborate setup, and it's not come in a day or two. It has come over a period of so many years. I mean, it has been so many committees have worked over it and given suggestions, and it has developed over a period of so many decades. So a lot of programs have been have been developed, and they have integrated into various complex set of programs. If you just talk about rural development programs, you have, other than the healthcare programs, we have a lot of programs, right, starting from community development programs, projects in 1950s to Panchayati Raj, to land reforms, to poverty alleviation programs, then the tribal development program, drought prone area programs. We have a list of programs which have happened for the benefit of the rural society, rural for the benefit of the rural community. So, and even in fact, if you talk about healthcare, recently we had a Delhi Declaration in 2018, wherein which was one of a kind, the very first time it happened in 2018, just before COVID. Wherein the motto of that declaration was, it was specifically meant for Southeast Asia, and all the around 40 countries had participated in that conference in Delhi. And the main motto of the final declaration that they finally signed was that people living in rural and isolated areas have to be given special priority if we have to reach the if we have to achieve a universal health coverage. It is not just for India; it's for every country. So if we have to achieve universal health coverage, rural areas have to be have to be addressed, have to be given special priority, because as of India, as of today, the rural population that we have is at least 68.84%. Even in spite of all the development that India has, and all the all the power that we carry, all the soft power that we carry, but in spite of that, still we have a lot of rural population, and of course it is not practically feasible to convert every rural area into an urban area. Obviously it's not possible. So and it's not even sustainable, because it won't be sustainable for the environment as well. So we need rural areas which are sustainable. So we need to make smart rural areas smart. Instead of making smart cities alone, we need to make smart rural areas, while healthcare and every other public policy is accessible to every part of the country. So that's from my side. Thank you.
Yes, wow, that was really dynamic. That was really something nice, Ganesh. I would like to add to it. I also am practicing in rural as well as tribal area, and as a system of rural proofing. It's not rural proofing really, but as a system of healthcare delivery, what we have and what we have established over a period of time, like Ganesh said, it is not overnight the whole system that has come into place. We have a system of community health workers in rural area. So I think in rural as well as tribal area, what we have, and which is a something which is really unique to some of the countries, where there is this elaborate community health workers network and a role. I think this is one of the major aspects which has really helped us tide over even a pandemic like the current one. And one of the ways of rural proofing, I mean, we all have we just, the previous panelists have talked about what rural proofing could be. So yes, providing special attention, or providing or facilitating rural areas or tribal areas is one of the things. Now, in India, we have these community health workers are called ASHA. Most of us know this. ASHA is also an acronym for accredited social health activist, and similar or counterpart does exist in urban areas as well. But the role that this community health worker plays in rural area is crucial. It is pivotal. It is the helm, or it is at the helm of all these programs which are launched or which are envisaged by government. So at the ground level, if there is any system for rural proofing, it is rooted through this community health worker, and that is why it makes this community health worker one of the major aspect of rural proofing, I think. Sneha.
Thank you.
I would like to add to what Dr. Ganesh and Major Kelkar have just stated. In 2005, the National Rural Health Mission was set up by the then Prime Minister. The main aim was to focus on empowered action states. That is, we have 8 states, and the northeastern states and the Jammu and Kashmir state. So it was implemented with the name of strengthening these areas, strengthening these states due to their not so good health indicators. And NRHM mainly focuses on WASH component, education, social and gender issues as well. So, and at the 73rd or 74th year of independence, we started, upgrading our sub-centers and primary health centers to health and wellness centers. So, rural proofing in India has been on a developmental stage, and as Dr. Nair rightly said, it was not over a short span, but an investment that the country has been doing over a period of like 7 decades. So, and at 75th year of independence, we are aiming to upgrade at least 6,000 to 8,000 PHCs and sub-centers to health and wellness centers.
Thank you. I think, can we finish the Indian perspective? Dr. Chandni or Dr. Shatabdi, can you add on?
Yeah, I just wanted to add a point. Yeah, Shatabdi ma'am, would you like to?
Yes, you can continue. I will tell you.
I just wanted to add a point. I was just reading an article few days back, and it was on what amount of money and what amount of health workforce should be given to the urban and the rural area. So I just read that total population, as Dr. Ganesh said, that 68% of the whole India population is in rural, and only 30 or 35% is in urban area. So I was really astonished to see that the percentage of doctors and the nurses is only, doctors are only 31%, and the nurses is only 36 or 37%. And some states like Punjab and Maharashtra, and they were having 0 or 2% of doctors or nurses in the rural areas. And that was really, really heartbreaking, because rural population also has the same right as of urban to get the proper healthcare and proper facility. Not only healthcare, as Dr. Asita said, that not only healthcare, all the facilities, but as a developing nation like India, we are from a developing nation. So every aspect should be considered for the rural proofing, healthcare, economics, their education and everything. So this was really, thank you.
Can I add something?
Yes.
Or is, yeah.
Go ahead, Anju.
Yeah, so, well, what I do understand from rural proving in health policies is that it is a generic impact assessment tool that is used to assess potential impacts of health policies on rural communities or remote communities, and also used to adjust the policies itself to ensure their relevance to rural context. But in the context, in terms of Indonesia, well, as I said it before, I don't think we have it as of now. And also, well, I do think it's important to have a rural proving health policies, but then again, I think it really needs to be tailored to the needs of the local population. Yeah, and I don't think it will work in the country that has that are heterogeneous and high in diversity. Yeah, well, that's my opinion.
One thing is that, yes, it has been actually mentioned properly, that is rural proofing or the rural impact assessment, and in many countries like ours, India, that is it's progressing a lot in the rural areas. There are our own workers like the ASHA and other workers like the ANMs. But one thing that still now we are much away from our actual aims and objectives. the works are going on, but availability is there. But still some of the service provisions are not being actually utilized. While we have worked with the utilization of the services, but even the maternal and the child health care services, that is the most emphasized national health programs for India, and I think for many of the countries also. But still the utilization is much less. We are working hard to create the awareness. We have many visible success stories like the elimination, eradication of a number of the diseases, control of a number of the diseases, communicable diseases, vector-borne diseases. We have control over them. But still now we have to work a lot to make the access towards for the rural community, towards the underprivileged people, that is services are available. Our ashas, they have worked much things, that is the people have been aware, but still the things which are in pipeline, which are we are doing, we have to work for them too.
Interesting perspectives. Asma, would you like to add anything from Pakistan?
First of all, what I understand by rural proofing, like it's something that all the policies and programs, to review all the policies and program in sense of that it should be it should be for the rural areas as well. Rural areas and rural people are very important for us because it plays a very important role in the economy of the country in terms of agriculture. When it comes to Pakistan, Pakistan is an agriculture country, and most of our communities live in rural areas. So the infrastructure of the rural areas in a past couple of years is upgrading, but when it comes to health sector, there is a lack of facilities, and we don't have much public health specialist over there. And although we have established some primary healthcare center, but still there is we have a lot of deficiency in terms of health specialists, and there is no proper medicines and rest of things. And when it comes to the doctor, we have a very low rate of doctors in the rural health area. So that's why most of the rural people living in rural areas, they are not able to get a proper healthcare services. In last couple of years, as I already told you, I was also working in a project in rural area. So some of the NGOs like a Rehnuma organization and some international NGOs are working to improve the infrastructure of rural areas, but still there is a gap. And now we are having new government policies to upgrade our primary healthcare structure and in line with the NGO sector. So that's why now it's getting a bit improved, but still there is a lot of work that needs to be done to facilitate the rural health communities.
Kin, would you like to add anything?
Yeah, to share our country context, Myanmar is similar to the other countries in the South Asia region. It's one of the low American country, and its economy mainly depends on the agriculture. And then more than 80% of the population are residing in the rural area, and moreover, rural area have the higher proportion of the impoverished people than the urban areas, 6.7 times higher poor individuals in the rural area. So in the term of the previous civilian government, rural development strategy framework was formulated in the 2014. It was already included to invest in the not only health area, like other public policy services, including improve the
infrastructures and like road networks and also electricities and also other livelihood conditions. But I think it was implementing under the other sectors of other sectors like rural development ministry or something like that, but it needs some integration with the other public policy like the health departments. And also also we also the outcome of this strategy framework, we don't know the result the impact yet. How much how much the activities under this strategy framework are implemented, or how much is finished or ongoing yet. And also in terms in the health areas, like especially in the UR area, only public health facility like the UR Health Center and SAP centers offer the primary health care, and rural population receive the primary health care or in their area. And also there are some other challenges in the UR area, health system challenges in the UR area until now. In the like previous civilian government, they formulated the national health plan to cover universal health, to achieve the universal health care coverage in the 2030, which also we expect to cover the to implement the township health plan, and also providing the health care services to the your health care activities. Yeah.
Thank you. We do notice a common trend across Southeast Asia. So I think I'll come to my next question to the panel. So what exactly do you think should be done to secure a positive future for the rural communities in your region?
Can I start?
Yeah, sure.
Okay. Well, in terms of securing positive future for rural communities in my country, I think the keywords are relevancy and also sustainability. And I think in order to reach this objective, I think doing a continuous assessment of the local population need and challenges in reaching and improve health, environment and outcomes, which in turn can be integrated into the policy itself and its assessment tools, is very essential. And just to give practical solution or example, I think, because I do believe that health is affected by an array of social factors that operate on multiple levels, and addressing this much broader set of factors is essential to create more sustainable health programs and a healthier and safe environment, especially in the developing countries. I think by integrating social data into population health analytics platforms, which in turn can identify social factors affecting health that exist in the population, is going to be a really great idea. And I think by developing such a technological solution that can identify and map social determinants of health that doesn't only act as a risk factor, but also as a protective factor, I think we could improve population health outcomes by means of, first of all, prioritizing specific intervention for high-risk populations. Second, achieving health equity across community, and lastly, building resilient communities, which is, I think, very important in the developing countries. Yeah, that's from my side. Thank you.
Interesting.
Yeah. It's all about
I would like to add, according to me, in our area, government is giving National Rural Health Mission and is if we take a point that they are not paying doctors, that is not the thing. If the government is giving an ample amount of money, if money is a factor, then that is also not also a point. But the point is, even after getting a good amount of salary, which is a considerable in this era of things are going, prices are going high. But the fact is that even getting a ample amount of salary, still people who are posted in the rural area, dental workforce or a physical practitioner, they are not going to the rural area. Why? Because according to me, this is because of the lack of facilities urban setting is having. If a, for example, if I am a profession from dental, so if I am going to a rural area, the problem is that if I want to treat the rural population, I don't have a proper dental chair working. The materials are not up to the mark. If I want to put some materials into the fridge, the electricity is not there. So according to me, first these points are to be considered so that we can give access to every kind of healthcare that the rural population is getting.
To add more to what Dr. Chandani has told, yes, completely agree to that. Rather than exorbitantly increasing salaries, which is not the case in India, but we need to strengthen the infrastructure so that the physicians working at the healthcare professionals working in rural setting are able to deliver care, right? So we need to create that conducive atmosphere to these physicians and healthcare workers working in the rural areas. We need to there is a gross disparity in how the medical workforce in India is located. Recently, I was seeing a tableau visualization there, and I just saw that for Karnataka state, of the 122 nephrologists present, although it's a super specialty, we have only 30 or 31 of them working in rural areas. So that is district headquarters, not below that. So we need to ensure that this disparity can be reduced. And how will that be reduced? By ensuring that there are proper services, there is proper infrastructure and facilities for these people to perform in their areas. Lot of emphasis has been laid on tertiary care, not just in India, in typical LMIC and some high income settings. A lot of emphasis has been laid on tertiary care and specialists and super specialists. We need to bring the cloud out from the system and tell that primary care, family physicians, general physicians, community health specialists are the people who are required to run the system and prevent the country from going and tumbling down in another pandemic. Third thing is to we have, Dr. Ganesh rightly spoke about the Delhi Declaration, but yes, we have adopted it. Now it's time to act according to it. Another point is rural-centric policies have to be developed by factoring in the diversity that India has. We are the 7th largest country in the world, and one-size-fits-all approach might not be helpful when we have such a large country. Northeast has a different terrain. Probably Dr. Kelkar would be the right person to comment on that. So Northeast has a different terrain. South India has good health indicators, but when we look at the remote villages, we are still lagging behind. So we need to address issues on absenteeism and labor turnover in these rural areas. So what I feel is we need to use a co-design, co-creation, and co-production of public health kind of an approach to somehow try and bridge this gap that is existing. Thank you.
Just adding to what Dr. Nachiketa said. Sorry, Dr. Asita wants to speak.
Yes.
Yes, please. Please go ahead.
Context, agreeing to all of you. Yes, thank you, Ganesh, again. And I heard from Indonesia and as well as from India. I think we need to give more towards rural communities. Our economical as well as political stability should be there. So currently we experience very uncertain and destructive things in Sri Lanka. Political as well as economical instability is there. So for the poor and rural communities, which is 80% of Sri Lankan population, it's 21 million people. So they need to reach and go to more future, secure and positive rural health. We need political as well as economical stability. To achieve that, the government should have a policy, national policy, which should not change with any regime which comes to power. So I reiterate that national policy should be always implemented, that we have given only 6% of gross national product to health. It should go to rural communities as well. But I think it is not done by any government so far in Sri Lanka. So they have not given full 6% from the GDP to health. So I think we should also think about these aspects as well, being some political corruption as well as economical hardships people endure because of lack of systems. And sometimes political leaders do not understand this and they do not care. So I think we have that aspect as well. Over to you, Ganesh.
Yeah, just adding to what Dr. Asita and Dr. Nachiket just said, one of my answers to this was that political will is very important to have a positive impact on the rural healthcare, because unless and until you don't have political will, no movement happens. Because if the government wants, everything can happen. Government is such a powerful body. If they want, everything can happen. I've seen that from first-hand experience. When the government decides to do something, if they decide, they can do it. That's for sure. So, but for the political will to come up, there has to be some pressure on the politicians from the society, so that they start working in that direction. And for that to happen, there has to be awareness in the society, that we are lacking something, that there is something lacking in us that needs to be worked out. And for that, government has to start working on it. But until we are not aware as a society, we will not put that pressure on the politicians as well, on the bureaucrats as well. So for that, we need to have increased social awareness. So many of the social determinants of health, which I'm sure that Sneha would be asking in some time. So many of those social determinants of health, one of those social determinants is education. Other than income and unemployment and food insecurity, all those things, education is also important. So if you have to have social awareness, you need to educate people as well. So as we are coming out of poverty one by one, as you educate more and more people, there is more social awareness. And as there is more social awareness, obviously it puts a pressure on political parties to work towards the betterment of the society. That's one thing. And also just to add what about NRHM, what Dr. Chandni was saying, there is a lot of money in NRHM, but the policies are a little different when it comes to various states. Because I was working in Uttar Pradesh, so I've seen that there are two sets of, if you just talk about ANMs, auxiliary nurse and midwives, who basically take care of the vaccination part of the government immunization program of the government in India. There are two types of ANMs that we see. One is regular ANMs and one is contractual ANMs. So the contractual ANMs are the ones who come from the NRHM. They are funded by NRHM, and the regular ANMs are usually part of the state government, which are paid in full. But the contractual ANMs are paid very meager. It might be just 1/5 of the salary which the regular ANMs are getting. But they are doing the same amount of job that a regular ANM is doing. So there have been multiple strikes which the ANMs have done in the past, and it continues to happen just for them to have a hike in salary. If the regular ANMs are earning around 70 to 80K per month, the contractual would be earning around 15,000 per month. So that's a huge gap of salary, 15,000 rupees and 80,000 rupees. So so that is something also that needs to be, so that differs from state to state. This may not be the same case in every state. Every state has their own, because down south the systems are much more advanced and much more better. But in many other states that's not the same thing. So but every state needs to look into all their policies, and they need to improve their policies so as to what you say, to finally the benefit is for the community only. But when you keep your healthcare staff happy, automatically that will reflect on the community as well. So you won't have frequent strikes or loss of jobs as well. So so that's from my side as of now.
I would like to speak as well. Like my previous esteemed panel, they have touched upon many points. And the most important are sustainability, or yes, government efforts and political will, Ganesh, yes. And there has to be a conducive environment which is provided to the healthcare workers, and the care has to move from tertiary to primary care, and from the apex or advanced centers in rural area to the screening services, more and more of general or family oriented medicine, etc. And last, that Ganesh very rightly, I think I really agree with it, is education. I think when we are talking of providing equal health, and we are talking that the doctors aren't present in rural areas, and that the rural areas there is a brain drain or things like that, the root cause remains in our education and education system. In India, ancient India, every village was self-sustained. There were all elements that is required for a complete society, for a complete community, were present in each of the village. Through over a period of time, with change in situation, this self-sustainability or self-dependence has gone. And there is these kind of sentences where we say we have to do more for them. They are not any other people, they are us. We are all one. And I don't think it is something that is something else that has to be done. But at a basic level, right from the start of the education, there has to be an equality, and not just on the books, in the papers, but in the young minds of children. India is right now working on it. We have the new education policy, and it is not only in the schools. Yes, schools teach all the ideal stuff and all the ideals, all the right things that Mera Gaon, I mean, my village, my this thing. Over a period of time, over a few years, when I realized that my Gaon does not have, a secondary school, and I'm leaving my Gaon for my school, then I'm leaving my Gaon probably for the college, then I'm leaving my district for probably for a medical college, and I'm leaving my country for the whatever super specialty that so is there anything wrong in it? No, I don't think. What is needed is when I am equipped with the skills, I am giving back to the community. And that sense comes only and only if it is being inculcated right in the beginning. So now the kind of reforms which are coming in the education, not just the school education, even health education is being reformed, where in previous times, medical students used to be introduced to rural health or, rural setup scenario towards later in their curriculums. Nowadays, right from first year and even before that, the medical graduates, medical students, undergraduate students are expected to be in connection with, in contact with rural community as a mandatory requirement for your passing every year. So this community medicine has come in a big way in the education, and somewhere I think that is what Ganesh also means by education. That way we are creating a pool of people who actually think that these things are required, the rural development or the political will or the pressure that we require to build the people who would be able to do that are these people. And for them, we need to actually start way early, right from the beginning of the education. And that is somewhere happening, and which I am really proud of and very happy about. Again, I go back to sustainability. So a sustainable village or sustainable rural or tribal community, of course, it has to go, the technology, we cannot go anywhere without. We have to accept and adopt the newer technology. At the same time, the human interface has to be maintained, and not internalizing, but connecting or accepting a rural community as a part of mainstream is important. And for that, again, this education and the mindset or the school of thoughts, which starts right in the beginning of your learning or that stage, plays a major role according to me.
Yes, Dr. Major Ashlesha has very rightly mentioned that these things, creating the motivation and mainstreaming the people, it's truly very important. And very importantly, those things like the political will, governmental commitments, these things are very important. And some things like that, more community involvement. Community involvement, there are the community members who are representing the healthcare services like our ashas, but still the voice from the community more have to come, like as in the rural cafe. Like this, we have also a small story that is, we are there to create the palliative care cafe. We are in very small scale, we have started this. We all know that the palliative care is very small area, but still neglected and very important place. We are just have started because it is limited. It is in very limited area, and we need that more people to come with their needs. What are their need? That is the need assessment, and based on this, that is the community need assessment. Everything is planned, but still the actual need is something that is being felt or not at all being felt, and still is not taken care of. And another thing that has also been started in very small scale, that is the involvement, that the motivating, that is the CSR, corporate social responsibility. More they are coming, more it will be helpful for getting fund or getting access to the underprivileged people.
Also, one more thing that I would like to add, where I think Nachiket said regarding Northeast, and not just Northeast, yes, Northeast all the more because there is less of representation from the area many a times. And we just, for us, it's just many of us, we are, I am right now in Mumbai, sitting right now in Mumbai. So for me, it is far in the east, and it is a part of India in the Northeast. It's a whole chunk. But when we look at the actual ground reality, not just every state, but every state has many different tribes with different needs. Their cultural, their history and their geographies as well are diverse. Their habits, so there are two tribes which are just adjacent to each other. They have been living. One of them is completely a pure vegetarian a tribe, whereas the other one would eat everything that lives. And that is how it is in India, not just in Northeast, all around in India. We have a lot of diversity and the needs are also diverse. So I think what Shatabdi just mentioned, that a need assessment, I think need assessment must be made, and that must come from an informed community. Yes.
Just adding to what Dr. Ashlesha just said, Northeast has a history, a long history since independence. If we see, a lot of these northeastern states have been at war with Indian government. Like since independence, if we see that many of the tribes have had various issues with coming together with the mainland. For them to integrate with the mainland, there have been a lot of issues. I mean, it's not that the Indian government was wrong or the Northeast tribes were wrong. It's not about that. But whatever, because of maybe the lifestyle and many other issues that they have had, the first 30-40 years of the government has gone through a lot of efforts to integrate that area into India itself. If you see across various governments, right from Jawaharlal Nehru to Indira Gandhi to Rajiv Gandhi, to all the governments have made a lot of efforts to integrate that area into India, and that has been a major challenge. So it's only now over the past 15-20 years that we have seen Northeast people getting more represented in the current political scenario as well, and gradually things are improving. Obviously, it has been a very slow development, of whatever I understand, in terms of Northeast, the way the mainland has developed. I see Northeast a little slower as compared to that, but because of many other issues that they have had, so that I think that has contributed to the slow development of overall that region. And I think, but since nowadays things have moved, we have moved on a lot. We have moved on a lot in this, in terms of integration of the entire region. I feel now over a period of time, in the coming 15-20 years or 10 to 15 years, we would see much more development in the Northeast. There is already a lot of infrastructure getting developed in Northeast, a lot of migration issues being tackled by the government. So I think in the coming years, we are going to see a better picture of the Northeast as well, I feel.
Can I add something?
Sure, Angie, go ahead.
Yeah. Well, the question was about what role or what should be done to secure a positive future for rural communities in my region. So actually, as I mentioned it before, apart from developing a proper assessment of the local population's need and also challenges in terms of health, because the main topic today is about rural proving, I also think that developing a proper and strong monitoring and evaluating system is also essential. And now we talk about rural proving. I think, well, I wish we could have a more inclusive impact assessment tools instead of a generic impact assessment tool of rural proving that we have now. The one that takes social, political, ideological, economical, and spatial context into consideration. And also, when we talk about spatial context, and in the context of Indonesia, I wish this tool could put rural and remote communities into different boxes instead of putting it into one box as what we have now. And also the tool that assume that rural and remote areas require a special consideration to achieve health aspirations, either of urban areas or beyond. So not all about catch up the health outcomes of urban communities, but also aspire beyond that. And I think the thing about this diversity thing is not just about Indonesia, I think, because the colleagues from India also have mentioned before about the heterogeneity and also the high diversity that exists in India. So perhaps it will also apply to India as well. Yeah, that's from me. Thank you.
Thank you, Angie.
I would just like to comment on a few things that has been discussed. I completely agree with you. My other colleagues that they were mentioning that education is a very important element to raise awareness about it when it comes to rural community. Yeah, that's exactly the in some rural areas of Pakistan, most of the people are not aware that how they can get the services and what is better for them, and they cannot make influence on the political settlement. So it's really very necessary to educate the people, to raise awareness in order to sustain their health. One thing is, and the other thing, when it comes to the healthcare services, most of the budget and most of the services, when it comes to doctor and other things, they are basically providing all the things in tertiary hospitals. Like they are ignoring the primary healthcare unit and rural healthcare unit and basic healthcare unit. So in this sense, still if we are not too much economically stable country, so I think so rather than spending too much money on tertiary hospital, we can also spend some money on the rural or like rural basic health unit or primary healthcare unit. And as I already told you that some NGOs are trying to work for the rural community. So it will also be a good thing that if they work with if public and private sector will work together. So we can make a good healthcare services for them, and it's also a good thing to raise awareness among the rural health communities. So I think so. And one last more things, when it comes to that tertiary hospital, I don't know about the other countries, but I was also reading in some articles, there is we have a lot of resources. We waste a lot of resources. So rather than wasting that kind of resources in all the tertiary hospitals, we can save from there and we can spend on the our rural health communities. So that's from my side.
Thank you, Asma. In the interest of time, I have one last question to the panel, and I would like to hear your closing remarks. So what would really attract your generation of healthcare professionals into rural healthcare?
Can I start?
Yeah, sure.
Well, I think in this capitalism era, I think developing comprehensive interventions both in the education and also in the market sector will create a significant improvement. For example, in the education sector, I think some colleagues have mentioned it before, increasing investment in human resource development, for example, by developing a scholarship scheme, especially for students from rural backgrounds, that will bind the awardee to get back to their hometown or any other rural or remote areas for a specific duration of time, would be a great benefit for the rural communities. And also not just investing in the development of a scholarship fund, but also investing in the development of health professional school outside of major cities that has a curricula that reflect rural health issues and clinical rotation in rural areas. As for the example for the market sector, I think giving appropriate financial incentives is very important, and also creating a better living conditions, safe and supporting working environment, and also giving a proper career development programs, professional network outreach support, such as developing technological solutions for that. I think that are some of the examples of how to really attract my generation to the rural communities. Yeah, that's from me. Thank you. Sneha, over to you.
Yeah, anybody else?
I'll go.
Yes.
Yeah.
I'll go next.
Yeah, sure. Go ahead.
Okay. See, for a young generation to be attracted to rural healthcare, when we talk about young generation, especially the people who stay in rural areas, it's not a big problem to attract them to work in rural areas, because basically that's where they stay. It's basically the people who work, who stay in urban areas, for them to be attracted to rural a setup. They really need to, one thing, though it sounds very materialistic, it might sound materialistic, but they need to have good incentives, good money to be attracted to, because if they don't have, because basically when they have their a good life, living a good life in urban area, and if we expect them to work in a rural area, so unless and until for the majority of people, some people, they might be okay with working at lesser incentives, but a majority of people usually tend to avoid being involved in rural healthcare, basically because of lack of sufficient incentives and sufficient what we say, the facilities. So the facilities that they get in the urban areas, they tend to not get in rural areas, and that's why they tend to avoid. As and when it's not a one day job. It's again over a period, over months and years, as the overall community develops, as we develop smart rural areas and better rural areas with better facilities, and as the government also, obviously, when the government starts promoting rural healthcare more, with Angie just said, educating these people, you need to educate those people as well, and you need to, if it's doctors or any kind of medical healthcare professionals, we need to, I don't think we have sufficient, we have not stressed enough on the importance of rural healthcare, though we have an entire subject of community medicine in the medical curriculum, but I think we can do more in terms of in educating the medical professionals for rural healthcare. I feel that would also help in promoting rural healthcare amongst the young population, is what I feel. Thank you.
Yeah. Hi. I just wanted to add a point. Dr. Ganesh was rightly said that the incentive is also a very important point in attracting the people from urban settings to rural settings. But I just wanted to add a point that according to me, at the graduation level, when the people are having graduation in the medical field, uh, there should be a setting that a senior medical professional should be available at the rural centers, so that the internships which are going, or which are tend to be, we are trying to opt for a training or a kind of internship for the medical students. So firstly, there should be a senior medical professional there, so that uh, if a person is going abruptly to a rural setting, it will be very uncomfortable for the graduate students to just, so that at an early stage, if we are trying to making them comfortable, the graduate students, to making them comfortable with the environment of the rural settings, or the thoughts and the beliefs, or their what are their upcomings and everything about the rural setting, then it will be more easy for them to just, after graduating, they can just join after easily and comfortably. So thank you.
Yes, in continuation to Dr. Ganesh, I like to add one more thing, that yes, incentives are very much required, and also as Chandini has mentioned, that is the availability of the senior persons. It is very much necessary. And a few more things, like if a person is there in the rural area working for say 3 years, 5 years, if he or she gets the chance of the promotion first. And one thing that was started in my state, I think maybe, I don't know that is whether it was started in some other states or not. That is special, incentives in form of the marks in the post-graduation entrance that attracts a number of the medical graduates a lot. And one thing, that is some specialties we have seen sometimes, like as the rural surgery. And if in the rural healthcare, there are some provisions of the super specialization or specialization, then it can be, the people will be more attracted. That is, we are getting recognition. Like as we can get the example of Kayakalp. That is, Kayakalp is, you all know that the hospitals, they get incentive for maintaining the infection control and cleanliness. Like that, if the rural areas, for the rural hospitals, the doctors or the nursing professionals, they get some promotion. Like as in West Bengal, a few years back, our Honorable Chief Minister, she started one program or project kind of thing, that is felicitating the block medical officers, and of course giving some awards for the best performing blocks. That is very much encouraging, and it works a lot for people, especially who work day in and day out in the very underprivileged areas. So I think these things can be taken care of. That's all from me. Thank you.
To add to what Dr. Shatabdi, Dr. Ganesh, and Dr. Chandani said, I feel we need to create that conducive atmosphere, and that can be created by if a physician or any other nursing or allied health professional is working in rural area. We need to ensure that the the family gets other sources of income or any other perks, such as getting a seat in educational institute. It need not be educational institutes like the premier ones in the country, but at least if the state, since health is a state subject in this country, if the state can guarantee a decent education for those healthcare professionals working in rural areas, that itself would save up a lot of expenditure for a physician working in a rural setting, or any healthcare provider working in a rural setting. Then we need to have policies which last longer than the governments, right? As Dr. Asita rightly mentioned, the policy shouldn't get better of the governments. The government should be strong enough to ensure that these policies are sustainable. Okay, and amendments, yes, with time, all these things have to be changed. And I also feel that the medical college curriculum needs some bit of tweaking in, rather than whenever I speak to my colleagues who are in the hospital or who are in the who have just started off in government PHCs or even in the first year medical grads, nobody wants to take community medicine or family medicine. Everybody wants to become a cardiologist. Everybody wants to become a surgeon, specialized in one or the other thing. But why is that? So why is the cloud that is created, which looks always greener on the other side? It is because some, these specialists always serve in, exorbitant hospitals. But the crux of the matter is that until and unless the primary care is given equal importance, or in fact more than what is currently there, and until and unless we change that mindset of young medical graduates, young healthcare professionals, that working in the community is how the career starts, yeah, other things will definitely fall into place over a period of time. But yeah, again, since health is a state subject and has its own limitations and how it is getting implemented, few things where behavioral educational communication, which we call as in typical community medicine terms, we need to have that kind of a counseling for professionals, right? I saw, like, before COVID, I have seen many medical colleges where 3 or 4 community medicine seats have gone vacant for 2 to 3 years. And after pandemic, everybody felt that yes, community medicine or public health is the way to go forward. We don't want a pandemic to hit us to open our eyes, right? So we need to create those conducive environment for professionals to thrive in those areas, and only then will these health sensitive policies come into picture. And of course, yeah, it is decade long kind of an experience that is required, but these things can definitely help people, or help any individual for that matter, to think, yeah, rural services definitely a shot worth giving. Thank you.
Thank you, Gurjit. I agree with you. And in Sri Lankan context, we are allowed to practice privately in NYAMU-THENGA. because I'm a government doctor and I can do my government job and practice afterwards as a general practitioner. So rural community is 80% of Sri Lankan population, and Sri Lankan doctors are eventually attracted to rural areas, and they are not by force, but as an appointment basis, they are given a chance to serve in rural hospitals. So from Ministry of Health, they are given the appointments and the jobs in rural areas, and then they start their practices and they thrive as well. And our roads are being constructed and they have motorable roads, but some areas are not passable. So we have to think about that as well. Creating more infrastructure facilities as well. We'll just talk about the waters, because the doctors are maybe away from their hometowns and they are going more than 250 kilometers away from my home, like I do. And then I got established in this area where I serve, and I have many other perks. Also, I would like to suggest that continuous medical education for doctors should be provided in these rural areas. Most of Sri Lankan doctors lack that part, because we have to travel to Colombo, or either where postgraduate institute is only in Colombo. So we have to travel work, and that discourages doctors. So let that also remind some development if you think that should be done in rural parts like that. What do you say?
Thank you so much, Dr. Ashlesha.
Yes, thank you, Sneha. So I actually would like to take us all to the, Abraham Maslow's theory of human motivation. And it applies everywhere, including health sector. We are humans ultimately, although doctors. Yeah, so like we mentioned, regarding our basic needs, our good food, to have good lifestyle. There are some basic safety needs. Wherever I am, I should feel safe, including the gender sensitive situation. And then thereafter we have something like love and belonging. So like we just mentioned, that the families should be looked after, and that the families should feel something that, my son or my daughter or my whatever husband is doing some work. So, love, belonging, all those things are there. Beyond that comes is, so when we are talking of our generation or a younger generation, many of them are coming from a stratum where the basic needs are met. The basic needs of physiological needs, food, shelter, etc. And that with projects like Kaya Kalp, and the amount of money being pumped in the rural areas, the salaries are being met. And still, when we do not have, obviously there has to be something else apart from money or monetary. And what's that? That would be, I think, esteem. And I think Shatabdi touched upon it, where she mentioned about the awards, which can be, awards or felicitation or basically recognition. So it is recognition or esteem. That is what comes next. And most of us get over the basic needs, the safety needs, and the family related needs. And we ultimately, majority of us reach that esteem part. And even the younger generation looks for is of course monetary, but beyond that would be something where the self-esteem and the esteem in the eyes or in the community or in the society is something that we strive for, we work for. And with rural service or with rural medical practice, when that esteem, when that pride and the honor when it is attached, somewhere it is a very big driving factor. I know because I have served the armed forces. Many people think it is the pay and the perk which takes or makes one join these services, but it is not the pay and the perk. It is the pride, and it is the passion and the pride, basically. So not everybody can have passion for rural service. So what do you have? You can have pride attached with rural service, with rural health care, and beyond that is self-realization and things like that, where you have people like maybe in this year we had 2 such people who have worked in rural in India. I'm talking about right now completely. One is Dr. Himmat Rao Bavaskar. We all know him and his work related to in toxicology. And the second one is Dr. Dongre, who has worked for years. His entire life has been dedicated to leprosy. So 2 names which are from from rural service and have been given the highest of the civilians awards. So I think that recognition part, when it is attached, and the pride and the esteem, that when it is attached, it is something which will drive me at this stage to work in that community. And the second part is the technology. When we make, like right in the beginning, Dr. Ganesh mentioned, not smart cities, smart rural areas or smart villages. So when technology at the tip of my fingers, the places where I am currently serving, Sneha, even today, when I'm going there, I know that I am going to be cut off from everything else, which is many a times a good thing. But generally, I'm cut off from from the rest of the world. There is no internet and there is no phone network whatsoever. So and this is an area, a tribal area, which is say 20 kilometers away from a metro city. So that's the condition when it comes to technology and we are going towards advancement. So 2 things are extremely important, and one of them is technology for the younger generation to be there. Today, I am not able to function. I cannot develop myself. I cannot have contact. I cannot without technology. So making the best of the technology available at the last mile, and not just with the smartphones, it's with various other equipment, the equipment which can be developed with innovation and technology, which can probably, they are already existent, of course, where a disease can be screened or identified right at the point of care, rather than bringing the patient to a tertiary care just for a medical test, just like thalassemia for that matter. So now we have cassettes, we have kits where you can actually identify a trait, maybe sickle cell or a disease, and we are working on it right now in tribal areas as well. So I think technology, innovation, and something which goes beyond myself, something which I can leave as my legacy. So that kind of pride are the 2 driving factors for my generation or younger generation to work for rural. And I think that is that from my side.
Thank you, ma'am. Angie, I see your hand raised.
Oh yeah, thank you, Sneha. Actually, I just want to give a quick response to what Dr. Aslesha just mentioned before about increasing the self-esteem of the healthcare in the rural areas. Well, actually, we have this global policy recommendations from WHO released in 2010. It's about it's about the retention of health workers in the rural areas, and they divided the strategy to return, to keep the health worker in the rural areas by 4 categories, which is The fourth is about professional and personal support. And the last strategy is about public recognition measures. And that is exactly how we increase the self-esteem of the healthcare workers, which is such as creating rural health days and also giving awards to the healthcare worker, and also give titles at local, national, and international levels to raise the profile of those working in the healthcare sector in the rural areas. And also about technological solutions. I think I've also mentioned it before. I think it's also essential, especially in terms of creating a outreach support program. I think it's also beneficial to give a technological solutions to that program. And also, I just want to give a quick response to what Dr. Garnes just said about how it is not difficult to make the healthcare worker stay in the rural areas. I mean, those who come from the rural areas to stay in the rural areas. I personally think that the migration of health worker doesn't only happen at the international level. So it's not just about migration from one country to another country, but it also happened from rural areas to urban areas. So nowadays, I think it's also, it has become a problem. I mean, the migration from rural areas to urban areas. So I think, well, in my opinion, we should also pay more attention to that issues. So that's from me. Thank you.
Thank you, Angie. Anybody else? Any closing remarks? Okay, I don't see any other questions in the chat either. Takayani, can you just let us know if there are any other questions on the other live streaming? Okay, I don't see any other questions. I would like to conclude this session and thank our esteemed panelists. Thank you so much for being on board and sharing your valuable experiences and insights. From India, the entire Southeast trip was covered very well from your personal perspectives as well as professional perspectives. It was really nice to have you all on board. Thank you so much for joining us tonight and have a good weekend. Can we stop the live recording, please?
Thank you, Sneha. Thank you all.
Yeah, thank you all.
Yeah, can I request the panelists to wait for a minute, please? Can we end the live streaming, please?